So first of all, good morning. Thank you for joining the IMEDS community call. This is Christine Yu from the IMEDS team at the Reagan-Udall Foundation. So for the call today, we're hoping it will be a bit more of a discussion with the attendees interacting with the presenter as questions or comments arise. So if you are not speaking, we'd appreciate if you could mute yourself so we can reduce the background noise. If we have any issues later with this, I'll stop us and mute the group and have the open discussion after the presentation. Also, just to remind you that this call is being recorded, and we will be posting a recording along with a copy of the presentation on our website afterwards. One quick announcement from the IMEDS lab. The OMAP CDM version 5 is now available in the lab, and we are also now refreshing the MD-CD and CCAE data sets in the mini Sentinel format, and they should be ready very soon as well. If you have any questions about these, feel free to send me or Mark Cater an email after this call. So with us today is Dr. Ryan Kilpatrick joining us from Baxalta, and the title of his presentation is Risk-Benefit Analysis Using Administrative Claims Data, Some Considerations. The slides being used today were sent out this morning, and you should also be able to see them on your screen. So Dr. Kilpatrick, first of all, thank you very much for taking the time to be with us today. And with that, I'll now turn the presentation over to you.
Great, thanks, Christine. So a couple things. First of all, there is some construction here in the office, so hopefully that won't lead to any background noise. If there's a lot of noise, I'll try to put myself on mute from time to time. As Christine said, I was hoping this would be really interactive. I put this presentation together to try and, I guess, be a bit provocative. Not too provocative, but perhaps raise some questions I personally have, and I thought this would be a good forum to raise them, perhaps for more discussion or for more consideration. So it's a pleasure to present it today. So just a brief outline. I'm going to talk just a little bit about benefit risk evaluation, obviously not in any real detail, just to set as a setup for the topic. And then I'm going to talk a little bit about some thoughts and some considerations in the use of claims and electronic health record data. And then I'll talk a little bit about my personal view on perhaps what we can do in the drug development industry or the biopharmaceutical industry to prepare for post-marketing safety. And as Christine said, please, I really hope that if there's a question or a comment, that you can raise it and we can have a little bit of an active discussion, because this is not really a didactic set of content. More, it's really some of my own personal experiences and perhaps questions that I have about some of these issues. Okay, so I think, as we probably are all used to as epidemiologists, we'd love to have this complete understanding of benefit risk for any drug in all patients that potentially could be exposed to it. So we would want this complete understanding of all the causal benefits and harms from exposing each individual to a drug, and then we could make a very clear and objective decision about whether or not the benefits will outweigh the harms in treating a patient. Of course, as we all know, that's really never the case. And so in the absence, we use current evidence to ensure, and there's a lot of, I think, discussion ongoing about how we really arrive at a benefit risk assessment. I think it's a really interesting ongoing discussion, and there are quantitative and qualitative aspects to this, but getting beyond that, just sort of thinking, I guess, more high level about what that really means, and what we're really trying to do, and how we're going about maximizing benefit risk in really the margins, because we really only have a target population that's been defined really often through the clinical development program. And then perhaps and perhaps for various different reasons, not always because of the intention to maximize benefit risk. If that makes sense. So lastly, and as I think about this more and more, being in a drug safety part of an organization, there are consequences of this lack of information. Of course, there's consequences of never having all the information, and I think it's just important to consider the consequences on both sides of this equation. So on the next slide, I think a lot. Obviously, I work within a biopharmaceutical company, and I have throughout my career. So, I think a lot about the perspective that we have here, and we see many programs go through various different stages of development, and for various reasons, some of which we don't fully understand all the time, or I don't fully understand, these programs are terminated, and there are many reasons why that decision might be taken, but in many cases, it's because of benefit risk, and so I think that's important because the way I see it, by choosing to not develop something, or choosing who the target patient population is, or the target patient profile, I think we set the stage for approvals or denials that could affect. Of course, could harm patients directly by exposing them to something that doesn't benefit them or doesn't benefit them on the whole, but harms them. But also, I think the flip side of this is making decisions that actually prevent further developing or using products in patients that may benefit from them. So we have to think about, I think, both sides of this. And I know there are companies and there are ever sort of burgeoning methods to try and repurpose drug candidates or even marketed products for this purpose. But I think it's important to think about both what we do by exposing patients.
Sorry to interrupt. We are hearing some background noise, so if you could just please mute yourself if you're not speaking. Thank you very much. Sorry, Ryan.
So, yeah, thanks. So thinking about both sides of this. So, and of course, suboptimal benefit risk evidence leads to, and I think, a consideration is just all the misuse of resources, both, on the part of payers, reimbursement, government, taxpayers, the like, as well as industry working on programs that perhaps, they shouldn't be, or vice versa. So those are just some thoughts. So, this is where I'm going to get a little bit provocative, perhaps, because as I think about it, at least from where I sit, again, looking outward from as an epidemiologist in industry, a lot of the imperative in the post-marketing setting for evidence really concerns risk. And I think, a lot of times when, at least from our perspective, or from this perspective, talking about benefit, especially when it pertains to I'm talking about real-world evidence, and there are, of course, phase 4 studies. There are clinical experiments that are done in the post-marketing setting to try and understand better, benefit or perhaps different indications. But I think at least most of the time when I think about real-world data and I think about exploring benefit, the perception is often that that's done more by health economics groups or perhaps medical affairs, and that's not necessarily part of a requisite program to evaluate the product. I think about the stakeholders that are really actively involved in this evidence or in these studies in the post-marketing space, and really for many of them, rightfully so, their mandate is really around patient harm and risk. So, as I say here, regulatory approval, of course, is based on a favorable risk-benefit profile during the development program. And, the real-world studies, post-marketing commitments, past studies, of course, there are also post-authorization efficacy studies as well now that are coming into play. But most of these studies principally have a safety objective, and effectiveness is usually an objective, but it's often, at least from where I sit, it's often almost assumed that the product will be effective, and if it's not effective, that in and of itself is a concern. So it's not really about further evaluating real-world effectiveness as it is in sort of validating that the product does what we say it's going to do, which I think is somewhat of a little bit of a different question. And I think, of course, we know there's active real-time monitoring of risk, which takes place. I'll raise this. There's not such a parallel really for evaluating patient benefit, and I'll talk about that a little bit further in subsequent slides. So, I feel that to maximize societal value, we should be making a very strong effort to ensure that the benefit-risk profile includes evidence, the best evidence on both sides of the benefit-risk equation, right? We have a whole, passive or typical, pharmacovigilance program, which includes spontaneous reports and so forth. Of course, spontaneous reports of risk, and I think, it's important that we think about how we can best continue to evaluate both effectiveness and where benefit risk might be maximized in the target patient, in patients that are using the product, or could use the product. So I'm going to talk a little bit about one example that I've thought a little bit about. I shared this I gave part of this discussion at Boston University a little while back, a few months ago, and I thought I would raise it here as well for consideration. So, think a lot about the propensity score, which is used very frequently to understand risk and benefit risk using administrative claims data and electronic health record data. So, for many of you, you probably are very familiar with this, but the propensity score is used in many different ways. It can be used as a covariate. It can be used descriptively. It can be used as a variable to match on or within some caliber. And, of course, it can be used as a weight to weight patients, for instance, in an IPTW type of analysis, which could then be used in something like a marginal structural model. So what is it that we're able to see with the propensity score? So this is a figure taken from a paper published by Till Sturmer in 2010, and I added these red ovals just to kind of emphasize the point. Now there's a lot of assumptions here, right? So we develop a model for the propensity score, and I'm sort of assuming here that this is a model, really a treatment model, and of course we know some of the pitfalls of building propensity scores around, including, let's say, predictors of the exposure that are not associated with the outcome. And Alan Burkhart has talked a lot about that. There was a paper by Sebastian Schneeweiss and Alan that made the case that this perhaps is not as big of a problem as it theoretically could be. I think fortunately or unfortunately, instruments are not very easy to find. So things that are related really strongly with treatment, but not related to the outcome, perhaps are not that easy to come by. But I think intuitively we're talking we're looking at this assuming that we're not including just instruments or we're including instruments that are strongly related to the exposure, but not related to the outcome here. Okay. So in this case, we have these two non-overlapping populations, and we have two populations or two groups which have some level of overlap, and then we have a group in the middle which perhaps has the most of the overlap, right? And this, just to orient you, the solid line here are patients who were treated with whatever the drug was or therapy, and the dotted line are untreated, and the x-axis here is the propensity score. Okay, so it's from 0 to 1 on the propensity score. Okay, so in thinking about this, what can we say about these groups? And this is being a little bit. I think that there are some other scenarios we can think of, but generally this is sort of my take on these different groups. Okay, so we have these different clinical, I would say clinical buckets, okay, and I think they mean something. So we have this always treated group, which are the patients that pretty much have a deterministic treatment pattern, right? If within the covariates that you've included in your propensity score model, these patients are always treated. They would expect to always be treated, and they in fact are if you look at them in the distribution we just looked at. So it's that far right non-overlapping group. So who falls in there? So it could be that these are patients for which there's no clinical equipoise. So there's very strong evidence that these patients will benefit and in fact will be harmed if they're not treated. And that could be through compelling clinical evidence or just other beliefs. It could be that there are strict guidelines or strict formularies that dictate these patient groups should be treated. Then you have an always untreated group on the other end of the spectrum, which, given their set of covariates, they're never treated with the product. And so, you can imagine perhaps this is a group that's contraindicated for treatment, or that there's really compelling clinical data that they just won't benefit, or that in fact these patients would be off the label. Okay, and then you have these other groups. You have those that are treated despite a low propensity, and those that are untreated despite a high propensity. And this is really where you have some overlap in the two patient distribution. So those that are treated despite a low propensity, this is by definition an unusual treatment pattern by definition, right? So it's a source of good clinical variability. But we have to think, why are these patients being treated? Who's treating them and why? And it could be that they are being treated inappropriately. It could be that there's not very compelling clinical evidence to support the value of the product in that patient group. It could also be that there's unmeasured confounding, that we haven't included confounding. It could be confounding by frailty, which has been described, where perhaps there's a last-ditch effort to use a therapy that has very little potential to benefit the patient, but there's really no other option, and therefore the patients are treated. And then the untreated despite high propensity, this is another unusual treatment pattern in terms of frequency. And again, this could be due to an error on the part of physician. It could be that there's unmeasured confounding as well, by way of frailty of futility. A physician feels that there's just not going to be any benefit in treating this patient because they're very ill, and we might not be able to measure all of those frailty factors. It could be, of course, cost. It could be that there are issues related to cost or copay or insurance and coverage. Lots of different reasons. So who might we have? In some cases, who might we have in this analysis set, right? So we have, as I mentioned on the right tail of the treated distribution, we have, we may have patients for which there's very compelling evidence from clinical trials that these patients will benefit. There could be very clear guidelines with high levels of evidence, and there could be a lack of clinical equipoise to not treat those patients. So we're left with this group in the middle between these two bars. And this is not always the case, but I think sometimes is the case that these are groups of patients who have a moderate indication for the therapy. In other words, they have a propensity which is somewhere in the middle, meaning there's sufficient clinical variability. There's an unanswered question, if you will, in the real world about the benefit of treating these patients. So what does it mean to what does it mean to extrapolate to the patients with these determinate treatment patterns? So we use that middle group, right? We usually use some sort of trimming, and we use this middle group to understand, let's say, if there's a benefit or a risk. So we end up having some sort of measure of effect, and this isn't a fundamental flaw with the propensity score or the method itself at all. It's really about decision making and how we take that information that we gathered from that analysis and what we choose to how we apply that to broader patient groups, right? So we know for a fact that we're not able to study in the real world the effect of treatment among those who are always treated. Not directly, because there's no exchangeability as we saw in the propensity score distribution. So the patients with the determinate treatment patterns, we cannot measure the effect of the treatment in those patient groups using that method. So it limits our ability to make inference perhaps, about those patients who are most likely, in many cases, most likely to be using a therapy. Okay. You can estimate risk differences or number needed to treat. Although we have to make assumptions about the.
Hi, sorry, Ryan. Again, okay. Everyone, please mute yourself if you're not speaking. We're hearing a lot of background noises and echo. Thank you very much.
So we have to make assumptions about the relationship between the propensity score and the treatment effect. Okay, in order to extrapolate, if you will, into those different patient groups. There are other ways we can think of estimating the effect in those patient groups. Of course, using something like you can use historical time period, but when there was no equipoise, or before a clinical trial was conducted, or before guidelines were put in place, or before reimbursement decisions were made, and so forth. But then we're making assumptions that things have otherwise remained fairly consistent. So that's sort of one, I think, one interesting dilemma from the propensity score. And I think also as we think about it, or as I think about it, in that middle group, that group of patients that sort of have a moderate indication, in theory, would we be more likely to observe risks or benefits in this study group? I think it's an interesting question, because I think that the treatment is being used for the purpose of benefiting patients, but not for the purpose of it's not necessarily being used to drive the benefit risk profile. So I think this is a patient group in the middle who we're not sure will benefit. However, we may very well observe risks in that patient group, either because the patients were not really indicated, or they were not strongly indicated for treatment, and so does the benefit risk profile in that patient group, does it really apply perhaps to the entire group of patients who are receiving the product? Okay. So this is a quote from Till as well, and I put it up here because it's sort of the conclusion that I'm coming to, or I guess the question that I'm asking here. We limit to this group with moderate indication. Does this include the patients that won't be maximally benefiting? And I think Till said it very well when he says, it's reasonable to assume the treatment is most beneficial for those subjects who are most suitable for treatment, and this phenomenon may cause different treatment effects across the range of the propensity score. In other words, the ability to look at the treatment effects across the range of the propensity score is important, and we can't always do that. Particularly for patients who have determinate treatment patterns. Okay. So the next question is, can we identify benefit? How do we really best identify benefit? I'm not saying that I necessarily have the answers to this. I think it's an interesting question, because when we think of benefit, perhaps we think of the same kinds of outcomes that were used in the clinical program, right? Mortality or hospitalization or something like that, right? But we know that the range of benefits are obviously much more dynamic than perhaps what we might think of as the range of risks. And I think, risks often they may or may not come to clinical attention. And I think there are already many challenges with fully identifying risks using administrative claims data. And there's a recent paper that Alec Walker was a co-author of that was published in PDS just late last year, talking about some of the challenges in ensuring the algorithms that we use and that the outcomes that we're interested in really can be captured within administrative claims or even electronic health record data. So what does that say about benefits? If someone has has sudden death or anaphylactic shock, I mean that's going to be treated. But if somebody just feels or truly has significant benefit, a significant improvement in symptoms, in symptom relief, how are we able to incorporate that information into the benefit risk profile? And I think it's a little more challenging. It takes a little more active process. So I'm just posing these questions. I mean, do benefits come to clinical attention always? And I don't know that they always do. And also, I don't know that we always even know what outcomes are most important to patients. Again, we presume using electronic health records or administrative claims that the outcomes that are most important are these events that come to clinical attention, or at least that's all we can measure. But we can't use these databases to assess quality of life or patient-reported outcomes, or some of the other things, just like really great effectiveness, we might not be able to necessarily evaluate using these databases. And I think it made me think of the current ongoing interest in exploring social media and mining social media to try to understand the types of events and outcomes and benefits that perhaps are most important to patients being treated, and ways to incorporate that into our thinking around post-marketing real-world benefit-risk evaluation. So one of the last points I'm going to make is really about the role of the epidemiologist. And I obviously think a lot about this because I work within the biopharmaceutical industry, and I think about what my role is. And I think we have a unique role. I think we have a unique role because we get to see the product develop across its life cycle, and we have a charge to really accurately as possible characterize and as comprehensively as possible characterize risks and benefits of our products, to ensure that, again, that there's a comprehensive understanding of benefit risk as much as we possibly can about the product. So I'll talk a little bit more about this, but I think there are many opportunities that we should be exploring throughout the drug development, throughout the product life cycle, if you will. Everything from really working to develop a patient profile that makes good sense. Can we use good epidemiologic methods to try and steer our development programs in a direction that's going to maximize benefit risk? I mean, that's a great anchor point, I think, for starting this sort of framework that I'm putting forth. Helping to inform clinical trial development because, again, we want to maximize benefit. We want to understand which patients will benefit the most, while, of course, also considering some of the things that are important logistically in developing a clinical trial, like how long it's going to take and how many outcomes people are going to have and so forth, but there are other considerations. I think there is a really great opportunity to be proactive about post-marketing pharmacovigilance and safety. And by that I mean we have a lot of opportunity to really understand what patients are going to use our products before they're on the market, and what kinds of channeling and confounding might we expect. What kinds of data sources should we perhaps be trying to get access to in order to evaluate benefit risk? What kinds of benefits might we want to explore in the post-marketing space? We have a lot of opportunity to do that ahead of time. What kinds of algorithms need to be validated? I mean, we have an opportunity to put the tools in the hands of both ourselves and other stakeholders to make sure that benefit risk evaluation is as robust as possible. And I don't think we always do this. And in the next slide, I'll take it a little bit of a step further and say, we have these opportunities. We can put together protocol synopses. We can be very detailed in how we think benefit risk evaluation could take place in an ideal way, very early, much earlier than when the product is already ready to be launched, let's say. And I think we can get internal alignment within our institutions, perhaps within the broader community. We can, in my discussions, I've had discussions with people who are part of Sentinel and those initiatives, and I think everybody really sees the value in working together to try and do this in the best possible way. And who better to start this off than epidemiologists working on these programs in the industry. So I'm going to walk very quickly through an example, and the example really is to show some of my own experience with working with propensity scores, inverse probability of treatment weighting, and some of the challenges that I've seen, and some of the interesting questions that came up in doing this. It's really, this was really a question of risk, not so much benefit. But I think, interestingly, some benefit questions, I think, were raised as a result of this. And this really helped to drive some of my thinking that I laid out in the earlier part of the discussion. So this harkens back to a period of time while I was working at another company that manufactures a product called epoetin alpha to treat patients who have end-stage renal disease. And at the time, this drug, there had been several clinical trials in other populations, in different populations, that raised some concerns about the benefit-risk profile. And then there was also some real-world evidence, some real-world data that came from groups. This, I apologize, I don't know that. Okay, so the citation is there. It just got a little, it just got shifted a little bit. But this is from Dr. Zhang and Dr. Cotter. They were looking in real-world data, in a data set of patients being treated with ESAs, and they observed the following. So ESAs are used to raise hemoglobin, and hematocrit is essentially, we can think of as the same concept, right? So patients who are on dialysis, who have really very little renal function, are not able to make enough epoetin alpha to maintain their hemoglobin level, and therefore they often become severely anemic. And ESAs are used almost ubiquitously in this patient group to treat anemia, and have been indicated for quite some time to avoid transfusions. So that's the indication: transfusion avoidance. Without ESAs, but prior to ESAs, there were a lot of transfusions. Patients needed to have a transfusion to raise hemoglobin due to their severe anemia. So this figure shows an unadjusted analysis. There are three axes: mortality on the y-axis, and then on the x, hematocrit group with increasing hematocrit, and on the z, dose quartile, dose of ESA. And we can see if we look at this that if we look at that lighter blue color all the way in the back, that's the patient group that's on the highest dose of the product. They're in the highest quartile of dose. And across, on the margins, across all the different across all the categories of hematocrit, there's higher mortality in that group. Okay, so there's higher mortality in that group. And so Dr. Zhang and Cotter posed this question: the observed association between epoetin dose and survival. They were realistic in saying it could be explained by a lot of things, but it could also be explained by an unexpected effect of high epoetin doses, independent of any effect on hematocrit. In other words, it could be that the dose is directly related to increased risk. It could be harming people, was the question. So not to go into a lot of details, we don't have a lot of time, but this was a complicated question, and I think it's interesting because I'm not sure in this kind of a pharmacoepidemiologic scenario that I'll describe, it's quite hard to evaluate to estimate benefit risk. It really is. So in this scenario with epoetin alpha dosing and hematocrit or hemoglobin, the dose, as I said, almost everyone is treated, and the dose is titrated dynamically to try and increase hemoglobin to a target level. So we have this dynamic dosing scenario. And what ends up happening, if you try to tease this apart in a DAG or some sort of a causal diagram, which I'm not going to show, is that there's historical confounders that are also intermediates. And so you're in a tough situation because you can't really control for all the confounding without perhaps blocking effects through historical intermediates. And so what one approach to address this is to use a weighted analysis, which is essentially to build the analogous propensity score and use that as a treatment weight, the inverse of that as a treatment weight, and to do this in a time-dependent fashion because you're trying to build a time series, right? You're basically saying that prior values of hemoglobin and epoetin may independently affect the outcome, and so we're trying to build a sort of weighted treatment history window. And we did this, and what we showed, I think, one of the really important pieces is in this figure you'll see the simple, case mix, and expanded are several different levels, several different treatment models with increasing complexity, okay, with increasing levels of covariates of predictors in the treatment model. And then, as I mentioned with the discussions of propensity scores, there was always a need to truncate. And that means removing patients who have these determinate treatment patterns in the extreme tails of the distribution. And you can see here in the next column the maximum weight that was seen after the truncation took place. And then the different dose categories: 0 dose, category 1, which is the lowest, 2, 3, and 4 is the highest dose in the analysis. And I think the first thing we see is that regardless of the point estimate, that there's significant uncertainty. And what frequently I've observed in doing inverse probability treatment weighting is that we get a much better sense of our level of certainty. And I think there's a lot to be said about truncation and how that may affect our increase our supposed certainty or our level of precision, whether that's appropriate or not appropriate. But I raise this, and an interesting point. After this was published, Dr. Cotter asked the question, and I saw it. Raised the question about well, it's interesting that you did not observe a benefit. And I think that is an interesting question. Why didn't we observe a benefit? Well, I mean, the first part of the answer is, again, getting back to this issue of how do we measure benefit. First part is the product's not indicated to. The indication is not mortality. It's not a product indicated to reduce mortality in patients with end-stage renal disease. So we wouldn't have necessarily seen a mortality benefit, but it does raise a very good question, which is, how would we ever assess the benefits of this product in the real world? And I think, the next level of investigation that the team went down was really to try to explore benefit and to understand how to build up better that benefit side of the benefit-risk equation by looking at transfusion avoidance and by looking at downstream clinical sequelae that could have been prevented or avoided by use of epoetin. Okay. So again, just getting back to this issue of what to do with patients that sort of have these determinate treatment patterns. This was an analysis I did. It was an inverse probability treatment weight, same setup, same problem with ESA dosing, and what I observed, I did a static model. I just looked at one point in time at a baseline model, and I built one set of weights. And what I saw were these extremely large weights. So if you look, these are the IPTW weight is on the y-axis, and on the x-axis are different levels of deletion of if you will of removal of outlying weights. So it's what we would call trimming, so weight trimming or truncation. So I trimmed at different levels without including the weights as they were. There are weights that are so incredibly large that it would question whether this is a data entry error or whether the patient was inappropriately treated or exactly what's going on. 10 to the 17th, 10 to the 18th. And you can see that you have to truncate and you have to eliminate patients from the analysis in order to come to a distribution that would actually make sense and work in a model. And by doing that, we limit our ability to make inferences about the patients who are treated in those tails. And unfortunately, in this case, those patients in the tails were the ones that we really wanted the information about because they were the ones that were receiving very, very high doses. So, it's frustrating because in the real world, we have to deal with the variability that is observed under normal clinical conditions, and that variability in many ways can be driven by the clinical evidence and by equipoise. And so, some patient groups and some questions just cannot be addressed adequately, I think, with real-world data. So, and in the next slide, I wanted to highlight that, including these patients in the tails, and in a weighted analysis, it's different, of course, than in a propensity score analysis, because here, you're upweighting patients. You're weighting them according to the inverse of, let's say, their propensity, of their probability of treatment. And it can have a very large effect, whether you include or don't include those patients and what level of truncation you choose to use can have a really big effect on not just on those extreme patient groups, but on your level of precision across all the groups that you're studying. And I think this figure shows very nicely that, as unfortunate as it is, if we really want to include patients where there's minimal overlap in the propensity score, we have to realize that this is going to limit, perhaps what we can reasonably say about the benefit risk of the product in those patient groups, because we increase our uncertainty, rightfully so, because we're relying on much less data to make an inference. So I'll finish with this, and then I'd really like to hear some discussion. These are my takeaway messages. So as we all know, there's an increasing reliance on real-world data for decision making, and there's a rapid expansion of data access and methods and who the audience and stakeholders are for this evidence. I think first of all, consideration of the research question and what's supported by the real-world data is important. You have to think about what clinical data exists, what's the variability in real-world clinical practice, and will we be able to really generalize what we see in that overlapping patient population with patients who are perhaps are the ones we think are most likely to be treated because they're most likely to benefit. And I think really important is that we need to be proactive about setting the stage for appropriate benefit risk evaluation. And I think really being engaged externally. This is the epidemiologists in biopharmaceutical companies have really, I think, a great opportunity to start this discussion early, to get internal consensus and alignment. And I think there's a very compelling case to be made, that this is a de-risking activity for the product, not one that creates risk, that perhaps a spurious safety finding will appear, after the product is marketed. I think, in fact, it does the opposite. We're not trying to draw attention to potential risks. We're trying to work as a community to do the best we can at evaluating benefit risk in the most robust way possible, so that the appropriate patients have access to the drug, and those that won't benefit don't have access to the drug. So that's my call to action, is really that we work to really drive the science around elucidation of benefit as well as risk, and perhaps epidemiologists and industry can take this as a sort of call to action. We need to consider. I think we need to do a better job of considering early, how we're going to continue to evaluate benefit. What does that mean, and how can we continue to raise that as many other stakeholders continue to evaluate the risks. So thank you. That's it. That's my final slide. So I'd love to hear your feedback and your comments.
Great. Thank you, Ryan. Again, thank you for taking the time to be with us today. So like Ryan said, we still have some time left on the call. So if you'd like to ask any questions or have comments you'd like to add, please just sort of introduce yourself first and feel free to do so. Again, if you're not speaking, we'd appreciate it if you could just put yourself on mute. Thank you. Any questions or comments?
Hi, this is Emil Skosarev. I'm an epidemiologist at Novartis. I have the following silly question. So, and I will ask it first and then explain in a couple of sentences why I'm asking it. So, what is the purpose ultimately of post-marketing safety analysis? Post-marketing efficacy analysis or effectiveness. So the reason why I'm asking is this. So in clinical trials, we study both efficacy and safety endpoints, and these trials are powered for efficacy, right? So for safety, we may not always have long enough follow-up to see enough events to really say anything about that. So I think that's a legitimate justification for post-marketing safety studies, right? But I think the argument which is sometimes made for both efficacy and safety post-marketing analysis is that patients treated in clinical trials may differ from those in routine clinical practice in terms of some factors modifying the magnitude of the treatment effect on efficacy and or safety endpoints. So it seems like a valid argument, but then what do you do if you see disagreement on in efficacy analysis between level 1 evidence and clinical trials and then the post-marketing observational studies? As we know, the randomization ensures valid causal inference in the sense that we have a consistent point estimate of the sample average treatment effect, and the confidence interval with guaranteed at least nominal coverage probability for SAFE, right? While in observational studies post-marketing, we have systematic error possibly of unknown magnitude and direction. So if you do those post-marketing studies with observational designs looking at efficacy endpoints, and you find that the studies are in disagreement with what you saw in clinical trials, then what do you do? And obviously one possibility is that there is a confounding in observational studies. The another possibility is that this is this effect modification hypothesis, that the patients just differ in terms of effect modifiers between clinical trials and observational studies. So which one do you believe more, and how do you really reconcile the differences? What do you actually do in terms of guidelines, say, when you see such a disagreement between level 1 evidence and observational evidence on efficacy endpoints?
Right. Well, that's a good question. I mean, I'm happy to put a couple thoughts out there, and maybe others can comment as well. But I think a few things. First of all, I mean, there's certainly, as you say, there's a difference between efficacy and effectiveness, right? So even just considering a difference observed in real-world use versus the clinical trial efficacy, we would expect there to be perhaps some real differences, right? I mean, the patient groups are much more heterogeneous. Of course, there's adherence, and there's lots of differences in how a drug might be used in the real world versus the way it was used under really more experimental conditions in a clinical program, right? So aside from bias and other things you raised, which are very true, we're trying to take what was really a controlled environment to ask the question, can something work, and answer the question, does it work in the real world? And I think that's fundamentally different evidence. So it's asking in my view, it's asking a fundamentally different question, both of which are very important. So I think that's one. And I think it's not that there's not an attempt to understand benefit necessarily in the real world. I think a lot of times that's not viewed, at least in my experience, that's not always viewed as a valid R&D activity, and by that I mean, of course, there's interest in showing the value of the product, but is there really do we have a good systematic way to evaluate benefit that with the goal of really, again, continuing to have a robust picture of benefit risk in the post-market setting? And I think that's the question that I'm raising here. So I don't know if that fully speaks to your concern, but what do you do with that data? Well, what you do with that data, I think, try to optimize benefit risk. Try to understand who is benefiting in the real world and what those benefits truly are, and therefore to provide a fair and balanced evaluation of benefit risk for decision making. That would be and of course use the best possible methods. I mean, that's what we're trained to do, right? Is to understand bias and to be cautious and to be always, I guess, skeptical of our even our own findings, and to really probe and do sensitivity analyses and do things many different ways, and all the good things that we are trained to do as real world data scientists.
Great, thank you. Any comments or other questions?
I was hoping this would be controversial, so I was hoping someone would, raise some passionate comment about, benefit in the post-marketing setting. So please feel free to do that.
So this is Hui Fang Liang from Takeda. I have two questions. One question is kind of stupid. In your takeaway message on the screen, the second bullet point, so VIS, AVIS, what does that mean? Is it a typo? Or?
Vis-a-vis just means with respect to.
Oh, okay, thank you. The second question is, when you assess benefit risk, have you, because a study typically have multiple outcomes, so because when we do modeling, you just put one outcome at a time. Have you done, so from what I've seen, you did one outcome at a time, right? Have you done benefit risk modeling? Or?
There are really interesting benefit risk models, and I think that's very interesting. So exploring, everything from heat maps to, there also are there's a whole industry. I know there's a group. I'm not going to say the name of it because I don't really know enough about them. But there's a group that's really focusing on using both genetics and other information to try to predict where the benefit risk profile is going to be maximized, essentially by doing both, by where we would expect risk to be minimized and where we would expect benefit to be maximized. And I think that's really important and interesting. I think the other side of it just is what I said. We're so accustomed to just continuing to focus on the clinical endpoints that were used to drive the efficacy, the studies of efficacy, and to use those. I guess we don't even always use those, but let's just say to use those, try to understand effectiveness in the real world. And I think that it would be very important to consider, are these analytics, are these methods, and are these data sources, should they be augmented, and how so, or should we be considering how to best pursue benefit as well as risk? So I don't know if that answers your question, but I guess that's sort of my thoughts there.
Yeah, thank you. Yes, you did. Yeah, could I ask another question? So you mentioned like truncated weight. So is there a threshold that you could, when you do the truncated weight, so basically the proportion of patients when the patients with heavy weights meet a threshold, you truncating those patients out, like deleting them would be not good?
Yeah, it's a great question. I mean, when is deleting them not good? I mean, ideally, for that particular question, I think one of my points that I was trying to make for that particular question about what's going on with patients who are receiving the highest levels of dose, it was a very, very hard, and there were really very smart people who in addition were trying to help us answer this question, right? I mean, we had Ken Rothman involved, we had Marshall Jaffe at Penn, we had lots of great minds working on this question, and I had a very small sliver of that. I did one aspect of this while I was working at the company. But I think one of the things that I learned, and perhaps that was a little bit disillusioning, was wow, well in this patient group, it's really hard to say what's going on because they're pretty much always they're treated in a nearly deterministic way. In other words, patients who have certain levels of hemoglobin, there's almost no way they're not going to get the highest doses. And so how you separate that out, there's really no exchangeability. There's no if you will, it's a sort of it's the problem that I tried to raise with the propensity score analysis, right? You've got these deterministic patient groups, and so you have to realize that you really can't make inference. Now, if there was clinical equipoise and if there was clinical variability, and some people said, you know what, I'm not going to bother to treat that patient with low hemoglobin. I'm going to let them ride it out. And you felt pretty convinced that all other things being equal, that was the treatment decision that was made. that would have changed things a bit. And perhaps there were a few of those in the data set. And then once you upweight those patients, 1,000 times, you're left with, rightfully so, you're left with big, wide confidence intervals because you have big, big standard errors because you upweighted, a few patients a lot of times. So I think my point is, a lot of things I'd like to see, I'd love to see, does the treatment effect vary? Back to Till's point, does the treatment effect vary within straight up the propensity? And how much of the patient, what proportion of the patient population is being treated in a determinate way? Because again, you can imagine if there's a really good clinical program that was great at really nailing down the perfect target patient profile for the product, and the evidence was so compelling that it really drove clinical practice, that would lead to one picture of the propensity score. You'd expect to have a big group of patients on the high end of the propensity score, and they're all getting treated, and there's no overlap. If it's really an unanswered question, then you might have a lot more variability, and the reality is often somewhere in the middle. So, in that picture, if we look at that one overlapping group and we say, well, you know what? They don't really seem to be benefiting that much, or let's say this is the hazard ratio. Okay, it's X, and we see these couple of risks. We see the risk of this occurs with this frequency. Using that alone to think about the benefit risk profile might not necessarily, that might not apply to the patients who have the higher indication or are more indicated and for whom the clinical evidence is more compelling that they benefit.
Thank you.
Yeah.
Great, thank you. Great questions. So I guess we have 3 minutes left on the call. If anyone wants to ask any last-minute question or have any last-minute comments, feel free to do so. If not, then I think we can go ahead and adjourn the call. So thank you all again for taking your time out of your schedule to join us today. So for the next community call, it will be Friday, March 18th, and you'll see an invitation from us with the topic of that discussion soon. So again, thank you all, and thank you, Ryan. I hope you all have a great day today.
Thanks very much.